Today I'd like to share with you a presentation which I first delivered at the Informa Healthcare Funding Summit in November 2020. Psychotherapy, or the talking cure, is the first-line treatment for almost all high-prevalence mental health problems, including anxiety and depression. Psychotherapy is a treatment for trauma. Psychotherapy is a treatment for problems of great severity and complexity. It is recommended as an adjunct treatment in psychosis. Psychotherapy is a transdisciplinary endeavour. It is not and does not belong to psychology, medicine, social work, or any other guild. Receiving the right dose of the right therapy at the right time logically might improve the mental health of the nation, which decades of inquiries and current statistics suggest is a rolling disaster. However, some of the most experienced and well-qualified psychotherapists in Australia, who happen to have a first qualification as nurses, cannot practice their craft with people most in need due to their exclusion from access to the Medicare Benefit Scheme and related programs. This is absurd. Indeed, the way psychotherapy is conceptualised and funded in Australia is nothing short of absurd. Albert Camus, the late 20th century existential philosopher, illustrated his philosophy of the absurd with the myth of Sisyphus, who every day would push a rock uphill and then let it roll down again. And then the next day he'd start over. I can also relate to Sisyphus, as it seems that I and colleagues are pushing something uphill when we've raised the issue of valuing psychotherapy, psychotherapists and mental health nurses, those that manifestly have the skills and experience to deliver solutions to the mental health problems that face Australia. When I first raised this topic with the organisers of the conference, I explained that I had petitioned the Federal Minister on this issue several times. I and colleagues had undertaken research on the capabilities of mental health nurses to deliver psychotherapy, most recently published in the Australian Health Review, Australasian Psychiatry and the International Journal of Mental Health Nursing. We had authored editorial pieces, obtained over 3,000 supporters on a change.org petition, and drew attention to 16 studies on what was previously known as the Mental Health Nurse Incentive Program and the psychotherapeutic capabilities of nursing. But absolutely nothing has changed. So today, having done all the evidence-based hard yards, I'm simply going to point out the absurd. Australia's answer to subsidising psychotherapy is a program called Better Access. It was introduced in 2006 and by 2019 had cost over $6 billion to the taxpayer and clocked in at around $17 million of taxpayer expenditure every week. Better Access is really psychotherapy light, the provision of focused psychological strategies over 6 to 10 sessions. I don't want to diminish the great work that is done by some clinicians, but this is not rocket science. GPs can become eligible to provide the service with 20 hours of education. I know, I've taught them. Eligibility to provide Better Access has become the eligibility criteria for access to other psychotherapy item numbers, such as those for eating disorders. Better Access is by and large what pays for counselling at places like Headspace, and access to Better Access has become by and large essential to work in primary care anywhere. However, we have a problem, a very pre-COVID problem, which moved Curtis, a young person in Byron Bay, to start a petition to get subsidised therapy. He could not afford to see anyone in his local community despite Better Access. Curtis's message shifted a little bit post-COVID-19. Now he wanted more subsidised sessions. Of course, therapy is already subsidised. This was pointed out in the article on the previous page by Dr. Carr Gregg. Apparently the subsidies under Better Access are pathetic, and that's why people are charging such massive, what we call gap fees. Now, it won't be lost to the audience that $124 per hour is a lot of money, around $250,000 per year, hardly pathetic. And that $260 per hour, which Dr. Carr Gregg cites as the average hourly rate of psychologists equates to over $500,000 per year, just marginally short of the Prime Minister's salary of $549,000. What is more disturbing is the differential subsidy for exactly the same job under better access. Psychologists and medical specialists can charge what they want and claim whatever subsidy is available. A little bit of an aside absurdity. We recently celebrated 50 years of equal pay for equal work. People who do the same work should in principle get the same pay. However, under better access, health professionals doing exactly the same task under exactly the same scheme get hugely different subsidies, and there is no evidence that any of them achieve different or better outcomes. But this is not really the point I want to make. The financing of health services is full of inconsistencies, gaming, politics, and quite frankly, absurdities. The one I want to highlight today is that some of the most highly educated psychotherapists in Australia, some of the most experienced in working with the most complex, most risky, that is mental health nurses, their clients cannot claim any subsidy at all. When I first raised this with the Honourable Greg Hunt's office, he pointed out that Medicare items for mental health were under review by a committee of clinicians. A review stacked with vested interests. They couldn't or wouldn't change anything until the review was complete. And besides, mental health nurses could access Medicare item numbers like one of the chronic disease item numbers, where people can claim 5 a year if they wanted to. But that isn't and never was for psychotherapy, and is worth about $50 per session. Now let's roll on to 2020. An apparent or anticipated mental health disaster looms, and regulators such as APRA even initially called for the fast tracking of more psychologists and allied health professionals to meet demands. Meanwhile, mental health nurses were sidelined yet again. And to address the crisis, the most significant announcement was a doubling in the number of sessions that are eligible for a rebate under Medicare. Wow! The immovable moved, and now my petition with over 3,000 signatures calling for mental health nurses to be recognised went unanswered. Now Curtis claimed victory and got over 100,000 signatures. What may be lost on many is that there is no increase in capacity. There is no evidence that anyone is dropping their gap fees, that therapy is any more affordable. Indeed, the only logical outcome of this is that it will take longer to get to see someone. And at least anecdotally, this is the case. Waiting lists of 3 to 6 months. And whilst our allied health colleagues are booked up for months in advance and can charge what they want, such as the demand, mental health nurses with qualifications in psychotherapy still can't claim a cent in rebates. Absurd. Since its conception, better access has been inaccessible to many people because of urgent need, complexity, but mostly because of affordability. The response was to have some capped funding called ATAPs for people who couldn't afford the gap fee. This was remunerated more highly, but no gap fee could be charged by clinicians. Mental health nurse psychotherapists could always access this. However, better access eligible allied health professionals frequently put up their fees to the level of ATAPs, and if clients couldn't afford the gap, they got a referral by name for ATAPs. This made it difficult for any mental health nurse to make a living, although they did, by and large, by seeing the more acutely suicidal group or those that no one else wanted to see. Mental health nurses were once the envy of allied health because they could and did provide medium to long-term psychotherapy under what was known as the Mental Health Nurse Incentive Program. These were people at the top step in the stepped care model. Mental health nurses did what needed to be done, and frequently that was psychotherapy. The program specifications did not see them doing this. Rather, they were meant to be following some kind of medically driven plan. As specialists, they were more often wrote the plan. However, they gamed the system as everyone else does to provide what was needed and not to feather their own nests. As the costs relating to better access spiralled out of control, this program was frozen, subject to an evaluation, which was then quietly shelved and did not even cite any of the literature associated with the program. Nor was any notice taken of the objections to mental health nurses being treated as chattels, glorified practice nurses, and so on. The program saved money, was valued by GPs, psychiatrists, service users, and kept people out of hospital. However, demonstrating that something works doesn't seem to make any difference in terms of ongoing funding. Since then, these capped programs have been dissolved into the bucket, or more likely a small glass, of flexible funding for primary healthcare networks to administer and mend the steps in stepped care. Mental health nurses, according to the Department of Health and Ageing guidelines on stepped care, are apparently good for coordinating care, dispensing and monitoring medication, and referring to others. No mention of their capability or capacity or role as psychotherapists. So that is recent history. However, mental health nurses have been around for a long time. Indeed, nursing is the oldest regulated allied health profession, by far. It predates the invention of clinical psychology, social work, occupational therapy by decades. And since the formalisation of psychotherapy as a craft, nurses have been doing it, training in it, and adapting psychotherapy to those with the most complex needs. Most cut their teeth working for years in acute settings with people experiencing the most severe and complex of mental health problems, 24 hours a day. I and colleagues recently surveyed mental health nurses with an interest in psychotherapy, and we found this kind of profile. An experienced group of professionals who could rapidly be mobilised to improve consumer outcomes across the continuum of stepped care, and in response to increasing need during COVID-19. The fact that their clients cannot access any subsidy for treatment under the MBS and they're excluded from other item numbers is absurd. Clearly, numbers don't really talk to the absurdity of the situation. Even if we make comparisons between this profile and the entry requirements for eligibility to better access for other health professionals, which usually fall far short of these. So let me introduce you to some of these people. Well, here I am. This is me. 30 plus years working in mental health and about 11 years of full-time equivalent education. A diploma of nursing, a bachelor of nursing, a BA honours, a master's in mental health specialising in psychotherapy from UQ, a doctoral degree focusing on mental health recovery, certification in eye movement desensitisation, and over 80 peer-reviewed publications, including on psychotherapy. I've provided unsubsidised psychotherapy, but my passion is working with people with limited means, and I've undertaken work under the Mental Health Nurse Incentive Program, ATAPS, and indeed teach psychotherapy amongst other courses and programs which I coordinate. However, my clients cannot access a subsidy under Better Access. This is Angeline, 20 years experience in child and adolescence and family health in the UK and Australia. She is an expert in attachment-based interventions with children. She operates a children's mental health clinic with a focus on early intervention for families, caregivers and children aged 5 to 12. But you won't get a subsidy to see Angela under Better Access, despite there being a waiting list for many months to see such a specialist in most areas. This is Jenny. She is a trauma expert, a master's in mental health nursing, graduate diploma in counselling, EMDR advanced accreditation, and so on. Jenny operates her own practice, a genuinely private one. People come to her because she can and does help them, especially those with experiences of childhood sexual abuse, trauma, and adversity. But none of them can receive a subsidy under Better Access. This is my colleague John Hurley, Professor of Mental Health at Southern Cross University. He has further degrees in psychotherapy, as well as the usual track record you might expect of a professor. He, like me, jumped at the opportunity to practice psychotherapy under the Mental Health Nurse Incentive Program, where he's been working with those at risk of hospitalisation, the serious end of the spectrum for the last 10 years. That's under threat because the Primary Health Network believe that mental health nurses are not qualified to do this. He and every other mental health nurse that has been practicing in that district is under threat. And the most absurd thing is that none of John's clients can claim a subsidy under Better Access for focused psychological strategies. Helen is like many overseas trained mental health nurses who came from the UK, where psychotherapy is perceived to be a valuable skill and a component of health services. She undertook an undergraduate degree in CBT, focusing on CBT for psychosis. She has a vast experience in working with people with alcohol and drug issues, those with complex needs and first episode psychosis. She's provided specialist trauma-focused therapy in the military. Origin, you might have heard of Origin, at least recognised her potential where she is Associate Director of Translation and Clinical Consultant for the Australian Early Psychosis Program. She is an expert and has 20 years of experience providing actual therapy, but here she can't provide any subsidised intervention under a mental health plan. Absolutely absurd. Lastly, meet Peter. Peter is a specialist and an expert in working with people with eating disorders. She has 2 master's degrees, an array of qualifications, and 16 years in private practice as an eating disorder specialist. There is no one like her in her region. She used to provide subsidised family therapy for eating disorders under the Mental Health Nurse Incentive Program on a referral from a psychiatrist. However, that ice cube is dissolving into the flexible funding pool. It's hard to see exactly whom the Department of Health and Ageing or the Primary Health Network expects she should refer people to. They refer to her. She was even an expert on the MBS Eating Disorder Working Group, and now Peter is not eligible to provide services under the new Eating Disorder Care Plan, and her clients cannot access a subsidy for treatment because the new eating disorder item numbers are run through Better Access. I guess she could retrain as a different professional and then undertake a course that she's developed and teaches to be eligible to access subsidies for the work she's already an expert in doing. These remarkable individuals are typical of many mental health nurse psychotherapists. In one paper we recently published, we liken them to the platypus, threatened to near extinction and now rarely seen in the wild. It is remarkable that the few remaining have carved out a niche anywhere, but they have, and against the odds, they still find a way to make a difference to people and practice their craft. They have been treated abominably by successive administrations. It has been quite immoral how they have been treated as a means to an end, purely instrumental to medicine or the government's grand plan. However, from a utilitarian perspective, it is unethical that at this time of unprecedented need, when there is a gross skills shortage, when there are so few people with psychotherapy experience, with those with the most complex and severe presentations of mental illness, that mental health nurse psychotherapists are still excluded from the lowest tier of service provision, Better Access. It is immoral and it is absurd.